All right, ladies and gentlemen, without further delay, it is my pleasure to welcome you all back for the fourth session on information and health services efficiency. I will be your host for this presentation, for this series of presentation and discussions thereafter. My name is Heiko Gewald. I'm a research professor of information management at Neu-Ulm University in Germany and currently a visiting research scholar at UCLA School of Public Health. So, without further delay, may I introduce the first speaker. That is Niam, and he's giving a presentation called An Empirical Analysis of the Financial Benefits of Health Information Exchanges in Emergency Departments.
Well, I should better be on time. So, good morning, everybody. The study that I'm presenting here is, as already introduced to you, is on the benefits of health information exchange in the emergency departments. And we already know that, the healthcare expenditure is a major part of our structural deficit. And despite spending more than any other country on healthcare, in terms of quality and efficiency, we're not good as we should be. And given the problems with quality and efficiency, it's logical to think that the magical wand of IT can improve both quality and efficiency. So, as a part of the HITECH Act, about $500 million was allocated to states to go and build their own statewide health information exchange platforms. Despite the benefits of health information exchange and having access to patient records, which logically should only improve the quality and the cost of the healthcare, and also the significant support from both federal and state governments, there is no conclusive evidence on the success of HIE platforms yet. So, In this study, I asked this question of why we are observing this, and I have a couple of arguments. The very first one is that the providers couldn't or wouldn't participate in the HIE platforms. They should be able to use their EHR software in order to seamlessly communicate with these HIEs. Many of these EHR softwares does not provide that interoperability. And on top of that, this is a new concept and many providers were not using it. And even if they wanted to participate, these platforms are basically, very simply speaking, are a database. And just like any other database, you have to have enough data in this to observe any value. And there hasn't been enough data in these HIEs, so regardless of their quality and user friendliness and interoperability or whatever other characteristic feature you want to use, as long as there's not enough patient data on these platforms, you cannot expect querying them and using them lead to any significant outcome. And finally, in the studies that had previously looked at the HIEs, it has been very difficult to parse out the pure effect of having access to information through HIEs from the other confounding factors like the physician's decision to go ahead and query a patient's information on HIE or the patient condition. So there are some evidence in the literature that actually shows that for the patients for whom HIE was accessed, the length of stay or the readmission rate or even the probability of death actually increases. It's not because of the HIEs kill people, it's because the HIEs was used for patients in more severe condition, and the researchers were not able to parse out those confounding effects from the effect of having access to information through HIE. So in this study, we had access to the best case scenario. So we studied the HealthyLink, the regional health information exchange platform in Western New York, in which more than 95% of the major data providers are already pushing their data into this HIE platform, which means that if you're a patient in the Western New York area And you have, there's also almost 95% chance that if you went to a lab, radiology, or hospital, then your information is already accessible through this HIE. And the other thing is that interoperability is not a major issue. So if their information is there, and if you want to use it, then you can use it, regardless of your EHR interoperability issues, or even if you don't have an EHR at all, because HealthyLink provides an access channel through a web portal that it's just like a website. You log in with your credentials and you search for patient information, and if there is anything, you can view that. So this study has been conducted in 2 months over 2 emergency departments, and we asked the medical assistants to shadow a group of physicians in each of these EDs for 60 shifts, which basically means for every day that they were there, and query the HIE database regardless of the patient condition and without asking the physician. So basically they kept the HIE access rate at 100%, and by that, by design, we kept the access to HIE as a completely exogenous factor. So it's not being affected by patient condition, it's not being affected by physician's choice. These are the descriptive statistics of the patients. In the first emergency department, we had 310 patients whom their information was queried from the HIE database, and then there were 278 patients whom their information was not queried. But these are the patients who visited the same emergency department over the same period of months. So it's not like you're comparing apples with oranges. This is the same ED with the same facilities, with pretty much, the same management style in the same period of time. So nothing, changes outside of the experiment designs. And in the other emergency department, which was located in another part of the city, there were 157 patients in the treatment group and 381 patients in the control group. We looked at the number of the lab tests and radiology exams as our dependent variables. These are the number of tests that physicians ordered per patient during the time of the study. And the HIE is our main independent variable. It's equal to 1 if the patient was in the treatment group and is equal to 0 otherwise. And the model is a Negbin model, so we're looking at the count of these tests, and the coefficient of HIE is negative in both of them, which in plain English it means that the number of lab tests is expected to reduce by 25%, and the number of radiology examinations is expected to reduce by 26%. We have other controls here for physician characteristics. So we control for their gender and the years of experience, because we want to see if those are also going to affect physicians' decision to order tests or not, and to acknowledge the fact that physicians have different types of practicing medicine. Some of them are high utilizers, some of them are low utilizers based on their training and their own personal views of how to perform medicine. We also considered the number of lab orders, radiology orders, and also hospital transcriptions per patient per physician in the year before the study was started. So if you started the study in August 2014, we looked at the patient, we looked at the physician ordering behavior in the year before and controlled for that. So we acknowledge if a physician is by nature likes to order so many lab tests, and control that in our study. And the other one is to consider for patient condition. We would have loved to have access to diagnosis codes or acuity level in the emergency departments, but we were not able to get that. The emergency departments that we were working with were not willing to share that information. So we went and looked at the number of prior tests that were ordered for patients in the year before. and we were assuming that if you're a patient that has 5 hospital transcriptions as compared to the other one who has no hospital transcriptions, then probably you're a sicker patient than the other one. So we control for all of that, and the results are 25% and 26% reduction in respectively lab tests and radiology examination in the first emergency department. We run the exact same analysis for the patients in the second emergency department, and what we observe is that HAE has no effect on the number of ordered lab tests, but it has a much more salient effect on the number of radiology exams, and it reduces the expected number of radiology exams by 47%. Again, what we're observing here is that these are two very different emergency departments in 2 different locations in the city. And when I asked the registered nurse who was basically leading the team of scribes who were collecting information from doctors, that why do you think the lab test does not show any effect in the second ED, she said that it's an emergency department that mainly provides medical services to cardiac and neurovascular patients. So for those kind of patients, you have to have the most recent lab test. So regardless of having access to HAE, you still want to have the very recent lab test, so you go ahead and order those tests. In conclusion, I think this is the very first study that establishes a causal link between curing HAEs and cost measures, and thus supports the efforts on health information exchange through whichever method that you want to be. And I think there has been a study in BMJ looking at the literature to see if there is any evidence-based randomized controlled trials on the effectiveness of parachutes on preventing injury when you jump from a height, and they ever say that, we looked at the medical literature and there is no evidence. It's a tongue-in-cheek article which says that, so when there's no evidence, we recommend jumpers to not use parachutes because there's no medical evidence. And I think this is a very similar study. You don't need a randomized controlled trial to persuade the physician that when you have a patient in the emergency department, you better look at the medical history of the patient. However, we didn't have this, and unfortunately, these HAEs were always attacked by, all of these critiques that despite all of these support, you have not been successful. But I think they have not been successful because of the reasons that they really do not have that much of a control on. And the other highlight of the study is our use of scribes. We had hired a group of scribes to follow physicians, shadow them, query information, and show it to the doctors in a way that does not disturb the usual process of providing care to the patients, and by that we could keep the HAE access rate to 100% artificially. But in reality, it's any study that I've seen, it's between 5 to 6 or 5 to 7% of the patient encounters, which basically means that if we can come up with smart ways to redesign the workflow or to use the technology in a way to enable us to increase the access rate to higher levels, then we can expect to see much better results from these HAE platforms. And I finished 1 minute and 40 seconds sooner than I had to. Thank you.
Thank you very much, Niam. May I then invite the discussant, which is Thomas Martin of the HIMSS.
Thanks for the opportunity to get a look at this this paper, Niam, before it goes out for publication. A couple of big things. I really comment this more from a policy analysis perspective, and And we chatted just a little bit about this briefly before you gave the talk, and I think a couple of things, you talk in your conclusions about the richness of data. I think one of the challenges that we still have from a policy perspective is the lack of a nationwide patient identifier here in the United States. So I'd certainly love to see some discussion in the methods and the run-up to regarding the accuracy of the results, right? Could you identify any false positives where information was available and it could have been utilized, but it necessarily wasn't due to issues with properly identifying the patient, not necessarily participating or being in the health information exchange. The second, and I think it relates fairly well to the last discussion we had around patient-generated health data, is how do we go about incentivizing some of these behaviors, right? Because the challenge that we have now is refocusing a physician's attention away from something else and focus it now on pulling this information from a health information exchange, right? And it's no different than asking a physician to pull information that a patient may have already submitted, right? So I think as we embark on alternative payment models, as we go to rulemaking around MACRA and MIPS, which is the replacement for sustainable growth rate, I think it could be really interesting as a path forward to have some discussion around how do we maybe more properly incentivize a lot of these behaviors and allow the health information exchanges to really flourish. So,
Thank you.
Here we are. Looks good. So, let me introduce Mehmet Ayvaci. Hopefully that was halfway right pronounced. University of Texas at Dallas, who wants to present, does health information exchange move patients through emergency departments actually faster? Please.
I love the fact that he even didn't try my last name.
I'm a winner.
Thank you for the introduction. I just arrived today in the morning, and I asked, I don't know like how many minutes that I have to prepare, and Idris, the previous talker who's sitting in the middle, said I can use 30 minutes, so if I go beyond, he's the person who told me that. This is a joint work. We are studying the relationship between health information exchange adoption and reduction in length of stays and length of stay at the emergency departments. This is a joint work with Turgay Ayer and Niam from Georgia Institute of Technology and Zeynal Karaca and Herb Wang from the AHRQ. The number of emergency departments in the US in the last 2 decades has been declining, about a 13% decrease. And the number of ED visits in the same time period has been increasing, about 50% increase. Combined with lack of coordination and unavailability of patient records, the length of stay at the emergency departments has been increasing steadily, leading to the so-called crowdedness epidemic. For those who cannot see what's writing there, the physician is asking, your case is quite advanced. It's better to catch these things in the early stages. And the patient, to emphasize that he has waited long, he says, quote, it was only a small patch on my arm when I arrived here. In fact, indeed, length of stay at the emergency department is positively correlated with morbidity, mortality, patient satisfaction. It's an important proxy for resource consumption and an indicator of management efficiency. National Quality Forum identified median length of stay at the ED as an important measure, and also it has been, in hospitals have been using, although there is no formal guidelines, less than, for the 90th percentile for the admitted patients being less than 8 hours, and the same for the treat and release patients being less than 4 hours. So we are looking at the relationship between electronic exchange of health information and length of stay in the EDs. From an HIE perspective, ED is a common application setting, and there is a motivation to access to health information. Based on the seminal study by Institute of Medicine in 2006, they have, to address the crowdedness epidemic, they have identified health information technology as a crucial part for reforming emergency departments. Among the benefits of HIE that you might heard in this workshop HIE is expected to coordinate care and reduce length of stay. However, lack of quantitative evidence because widespread HIE use is recent and we are seeing more and more, and that evidence base is building up. The question of, do we have more robust evidence and what are the moderating factors is still a question. So how health information exchange and length of stay and the ED can work out, there are possible mechanisms. I'm just listing out, this is not an exhaustive list. But the first is by reducing, similar to what Niam has pointed out, by reducing tests and procedures, there might be some direct time savings. By providing the information to the physician, the clinician's understanding of the patient's condition can be improved, but this might increase or decrease the length of stay because the patient, maybe the physician is going to do less, or they can do more because they are going to motivate their attention. Similar to other health information technologies, it can disrupt the clinical workflow, increase administrative workload, and possibly lead to behavioral issues such as information overload. And in what institutional and situational context these relationships are going to play out is unknown. Therefore, we asked the question of what is the overall HIE effect on length of stay for teaching versus non-teaching, when a patient is arriving to a crowded versus non-crowded ED, when the patient is severe or they have more comorbid conditions, does it depend on the disease? And we answered these questions using a large data set from the Massachusetts and exploit the variation in HIE adoption decisions to hopefully help the hospital managers to set expectations on what the possible benefit would be. In summary, our findings is the HIE adoption is associated with 7.9% reduction in length of stay, whereas patient population that we're working on, treat and release patients, these patients are admitted and released to home, which has implications for policy managers, policymakers, hospital managers, and researchers, ourselves. For hospital managers to emphasize, it can help with the patient satisfaction, it can increase throughput, it can improve the patients, the conditions on the patients who are come to the ED but they are left without being seen. When we restrict our analysis to those EDs where we know for sure that this patient has been to a hospital emergency department with HIE and analyze the same questions that we are asking for their subsequent visits, and we find that the reduction is further improved to 13.2%, so there's a scaling up factor. We also provide some contextual analysis as indicated in my previous slide, and hopefully our findings contributes to the discussion around Affordable Care Act, because Massachusetts has been considered as a mini model for the ACA. We have two broad literature contributions, management of health IT and also the interface of IT and OM, especially the ED, the many management papers that came out in the ED operations. And I will, and especially I would say that I'm adding on the literature that Niam has also brought up, reducing imaging and testing and similar work. The main question that I posit the HI implementation, what is the association between the length of stay, and we posit there's going to be a reduction in length of stay. Teaching hospitals, there are early adopters. 20% of all hospitals are teaching. They're usually tech savvy. They have been using internal information sharing in place, and it's already part of workflow, and therefore they have some experience. The hypothesis is teaching hospitals would benefit more from HIE as opposed to non-HIE hospitals. Crowding is an important concept for OM research. Some of the recent findings in the OM literature suggest that as the system load increases, workers speed up, sometimes avoiding unimportant procedures. Physicians, possibly, they can consider HIE access as an unimportant procedure. And West et al. 2014 confirms that physicians tend to use HIE less in crowded settings. Therefore, we posit patients visiting a crowded ED with HIE will not observe improvements in length of stay compared with those visiting a crowded ED without HIE. Severe patients, they tend to be in higher need of coordination, and they are subject to multiple procedures. Patients who have multiple comorbid conditions, they may require better information management. And interviews with physicians suggest that the HIE is going to be more useful for such patients. But we are asking, what is the benefit in terms of length of stay? Therefore, we posit severe patients visiting EDs with HIEs will have shorter length of stay than those without HIE. And secondly, for patients, we refer to them as complex patients, patients with multiple comorbid conditions. Those visiting EDs with HIE will have shorter length of stay than those visiting EDs without HIEs. We are using the State Emergency Department database from HCUP. We have access to a minute-by-minute length of stay at the minute level. This is the whole Massachusetts data from 2009 to 2011, and only the treat and release patients, which have about 2.5 million visits per year. We're combining this data set with American Hospital Association data, HIMSS data, and as well as census data. We are using a difference in difference setup, which has a control and treatment group, those hospitals that did not adopt during the duration that we are studying, and some of them have adopted HIE at some point in time. We are specifying 3 samples. One of them is the overall sample for an arbitrary patient. The second subset is we are restricting to those patients who are known to have a visit to a HIE carrying hospital. And third, using the index sample, we are asking the same question for 2 disease subsamples. We identified, based on our discussion with the emergency department physician, we identified strain, sprain, and headache patients as the primary condition. This is an overview of results. You see that the overall HIE helps move patients through ED faster, and there is a returns on scale. The index analysis is corresponding to the patients who have been known to have a visit to ED with HIE. Teaching hospitals, overall, they have a larger length of stay. It's confirmed by the medical literature. HIE carrying hospitals benefit more, possibly using the IT better. There are more opportunities for improvement in the teaching hospitals. That's also part of the explanation. When a patient visits a crowded ED setting, the reduction is not substantial, very small. But when we look at the scaling up factor and the index population, we find that about like 1.8% reduction in ED length of stay. For patients who have multiple comorbid conditions, we interestingly find that those visiting an HIE versus non-HIE hospital, in an HIE carrying hospital, they have more length of stay. It is possible that there is more time allocated to these patients due to HIE, and similar thing holds for severe patients. We are using the transport mode as a proxy for severity. So if a patient is arriving via an ambulance or helicopter, we posit that, we assume that they are severe patients. And we find that more time is allocated to these patients when they visit an HIE carrying hospital. Overall, when we look at in the index sample, there's an average of a negative 0.199 for the index sample. When we restrict our analysis to sprain, strains, and headache, we find there's a difference. And the reduction is more for strains and sprains, and it's less for the headache. It is possible, one explanation is their strain and sprain patients are more standardized care for, there's more standardized care for these patients. And for headache patients, the way that the physicians treat these patients, there's significant variation. The information available may evoke further workup. Let's say if a patient is visiting the ED for multiple times for the same headache condition, physician may start thinking about this patient has a tumor or other sort of things, and they might end up doing more. Therefore, the length of stay benefit is supposed to be going to be less. In summary, we observe reduction in length of stay when HI is adopted for an arbitrary patient, and there's also the scaling up factor. Hopefully, this is a good indication that as HIE is more widespread, the benefit is going to improve. HIE is associated with more reduction in teaching hospitals. In crowded EDs, relatively small or no change. For severe and complex patients with multiple comorbid conditions, this is HIE is associated with increase. In conclusion, there are implications for stakeholders, especially hospitals. Mentioning to the hospital managers, they would love to see some kind of a reduction in length of stay. Hopefully, this can help making the business case for HIEs. ED throughput being a significant issue, it can help with the, hopefully, HIE adoption as it becomes more widespread. It's going to help with the throughput and the crowdedness epidemic. We are using a large healthcare database, and hopefully we're going to see more of these in the coming years. Teaching hospitals, historically, they have longer length of stay. They can leverage on health information exchanges. HIE's help is relatively small in crowded settings, somewhat helping administrators to make a case against those who argue the workflow issues. Complex or severe patients, these are perplex decisions due to information overload versus more thorough examination of the patient. There needs to be more research on this domain. We have several limitations. I will conclude with this. We are only focusing on treat and release patients, which corresponds to about 81% of the whole ED population. Also, the length of stay is a is a sum of waiting and service times. We are not focusing on any quality impact. So, although length of stay is reduced, you may bring up saying that there's still quality concerns. Is it associated with quality improvement? And finally, we don't have access to the actual use data. In that sense, Niam's work is, we are complementary to each other, hopefully. And the use varies from 2% to 33% in different settings, in particular in the emergency departments. It's reported as 6.8% HIE use based on a 2013 study. That's it. Thank you so much.
Thank you, Mehmet. Unfortunately, the discussant, Jiban, cannot be with us today, so Gordon gratefully volunteered to skip in and give a few words of feedback. Thank you.
Thank you. So first of all, I want to say that I really love this paper. This expected method, right? So basically, right, let me tell you exactly why I love this paper as well as Niam's paper. So I think as health IT researchers, right, we are all quite passionate about the potential for IT in improving quality and efficiency. We have been working in this field, right, very, very kind of diligently, right, especially in the past 10 years. But many times, I would say most of the time, right, our results depress us. Right, so when we were doing kind of time motion studies, right, in the Children's National Medical Center with Ritu, and then we learned that how difficult it is to fit health IT into the physician's workflow. Right, they don't quite like the interface, and it may slow down their process. And then you have to use a big carrot and also big stick, right, to push the physicians to really adopt a health IT. When they have it, when they adopt it, what do we have? From yesterday's session, we learned that actually they do upcoding, right? And we see little improvement in the quality. Then, so we have to go to heterogeneous, right, effect to really identify which group of patients will benefit from health IT. So all this shows, right, some really, it is not delivering its full potential yet. So this is why I'm so excited to see in this session that there are significant results being reported, right? So from Niam's study, it is about more than 20% drop, right, in certain diagnostics tests. And then from Mehmet's research, right, is more than 10% reduction, right, in the length of stay. So this is really encouraging, and I hope that more and more results like this being published soon. And so as to, this research, there's a lot to like, right? So it uses a very nice data set, and then in Massachusetts. So, and it has applied, right, pretty, rigorous analysis, right, using a DID approach. So some of the comments I have really is, I think some of them already being addressed by Mehmet in his last slide. So one thing really is about, the usage of HIE. So we basically what you have here is some have it, some don't have it. Then this will be the indicator. But having the HIE versus the actual usage of HIE is different. And if you could look at it exactly how they use HIE, are they reducing diagnosis, for example, or they learn the condition of the patients better, so that they make decisions faster. So these are the mechanism. If you could figure out, that will be great. So the second thing I would like to talk about is really about the typical endogeneity issue, which everyone expects, It's like a knee-jerk reaction, to any kind of a DID. That is, there's a kind of, some hospitals chose to adopt HIE, some chose not. Then what's the reason behind that? Will this bias the results? So I think, you could do a little bit more on that. And related to the differences approach, one critical assumption is that the pre-trained, in the control group should be similar to the treatment group. So you probably could add a bit more tests on that as well to improve the rigor of the results. So finally is about your outcome measure, of length of stay. It's a sum of the waiting time and, the treatment. So I wonder whether you could separate these two, because HIE, in theory, shouldn't directly affect the waiting time, Because that's where when the physicians haven't engaged with the patient yet. So if you could split these two elements, that will help. And I'm also thinking, from operations management perspective, actually, think about the emergency department, as a kind of a series of events, The patients are coming in, Then they get treated, then they're discharged, So you probably could use something like, Markov, chain, analysis like that to model this process better. So because, if the patient is discharged early, then the next one will wait less, So basically, they're dependent, with each other rather than independent, So again, I think your approach is very nice, It's very typical and standard, in health economics. But I think, from other field, like operations management, that probably can give more insights on that. And we have an expert, actually, Dr. Barras here, so on this issue. So this is exactly what we have, So multidisciplinary, researchers, together, so we can learn from each other. Okay, that's it. Thank you.
Thank you. Thank you, Gordon. And now for the third presentation of this session. That will be Changmi.
Hello, everyone. My name is Changmi Jung from Johns Hopkins University. Today, I'm going to talk about this ongoing research titled as The Impact of Organizational Experience on the Service Operation Efficiency under the Context of Online Medical Consultation. This is a joint work with Rama Padman, Linda Argotti from Carnegie Mellon University, and Atif Mehrotra from Harvard Medical School. And the study is quite infant stage, so any suggestion or comments will be very much appreciated. So based on organizational learning literature in theory, as organization accumulates more experience, they develop routines. And this routine has, the routines are capable of endogenous change, such as more efficient work coordination. So overall, the organizational experience accumulates, then they will improve the operations efficiency. Then why do I care about this under the online medical consultation context? Based on Clayton Christensen's business model category, among three, two are quite prominent ones: value-added process delivery and the solution shop. And what's the difference? Value-added process delivery is what they are doing is they already have the solution. They already have the diagnosis on their hand. So they are repeating almost the same task processes. So as the time goes on, they will accumulate experience, and then their process improves. So their nature, the work is quite clearly defined, and the examples are manufacturing plants, shipyards, surgical hospitals like Aravind Eye Hospital in India. They only perform cataract surgery, and the restaurants, etc. But then solution shops' work is to find the right solution. So the key to the success is finding the right diagnosis, finding the right solution. And because of their work nature, the work process is less clearly defined. And the examples are consulting firms, general hospitals, even primary care practices. Most of the work in the organization learning literature is focusing on this value-added process delivery. But then a primary care practice that I'm going to talk about today and then online medical consultation are fitting in the second category, solution shop. Well, considering online consultation only takes on non-urgent acute conditions, maybe it's a lot simpler than general hospital and primary care practices, but at most it's still a mixture of the solution shop. So I'll just jump onto the hypothesis. So in this research, I'm going to be focusing on the two major outcomes of interest. So one is the turnaround time of the online service, online medical consultation service, and the other one is the coordination problems, because these two will represent, I'm going to talk about why, but these two will represent the operational efficiency of the primary care practice for this particular service. And they are affected by this e-visit. I'm going to use the terminology of e-visit exchangeably with the online medical consultation. So these outcomes will be affected by e-visit experience accumulated within the practice. So as they accumulate more experience, they will reduce turnaround time. So in other words, this is the evidence of the organizational learning. So that is the very first hypothesis. At the same time as they accumulate experience, the members of the practice will learn who knows what, who does this best. This is called the transactive memory system. So they will develop transactive memory system, which is the second hypothesis. And therefore, the coordination problem will be reduced. And not just this direct experience within the practice, also indirect experience from other practices within the under the same umbrella healthcare organization may affect the efficiency, work efficiency of my own practice. So this is called knowledge transfer, and I hope to see the evidence of knowledge transfer in this particular setting as well. So as other practices accumulate more experience, it also reduces my own turnaround time and coordination problems. So the first outcome measure, I used patient wait time. Well, the definition of the patient wait time is a little bit different than office visits, because in online setting, from the patient's perspective, it's not clear when physicians started to look at my condition and evaluate. So the entire chunk of time from the moment patients submit e-visit until physician responds, this is called patient wait time, and this, by definition, is turnaround time of the service. And the second outcome measure is non-value added activity. This is defined as the number of unique members within of the practice who accessed this online medical consultation before the very final responder opened it. So, and then access of the e-visit is defined as any activity, such as opening it up, reading, or closing the message, except responding it. So you can imagine that the higher the NVAA, the higher the non-value added activity, that means the more inefficiency, the more unnecessary human resources are wasted in resolving just one e-visit. So this non-value added activity represents coordination issue. The healthcare organization we worked had this ideal case, ideal protocol. So, and the ideal case, nurses work as gatekeeper, which means they will filter the e-visits and then assign it to the appropriate physicians. So in ideal case, before the final responder, who is physician, by the way, always physician responds. Before the physician, only one person is supposed to access the e-visit. However, we found differently. So case A, the upper one box, that is the ideal case. So only one person, staff A, read the message before the final responder. And the total wait time for this case was 26 minutes. But in case B, 3 people accessed before the final responder, and you can see the total wait time is 208 minutes, and it's quite complex case going back and forth. So illustrate this, patient submit the case, step B, read and forward, step C, read and forward to physician 142, and this physician forwarded to physician 64. And forwarded back to 142, forwarded back to physician 64. Finally, physician 64 responded back to the patient. Well, in this case, physician 64 was the primary care provider, PCP of the patient. And for the major independent variable, since I am claiming that organizational learning will be observed in this particular setting, the independent variables that I'm using here is the practice level experience, which is direct experience of my practice. So that is a cumulative number of e-visits served by my own practice up to the most recent e-visit. Then other practices experience is indirect experience. That is a cumulative number of e-visits served by other practices up to the most recent e-visit. So this one excludes my own practices experience. And since other literature that deals with the operations efficiency in service organization addresses that resources such as human resource material, spatial resources, and also the microenvironment such as the customer characteristics or patient's initial health stock influence the operation efficiency. I also control for task complexity and task familiarity, as well as the workload, such as the number of office visits 2 hours prior or post the e-visit, each e-visit submission, and the user message, telephone call, or the number of physicians available. So overall, a little less than 2,000 e-visits are addressed in this, used in this study. We exclude any e-visit submitted after hours or before hours, because in that case, the process is a little different. It goes to the call center, and then the call center is going to call the physician. So there's no staff involvement at all. So overall, the average patient wait time is 94 minutes, and in order to assess the effect on the patient wait time, I use the OLS with the logged value of the Y, which is patient wait time, and this is the fixed effect model, and I also control for submission time, day of the week, and month, year. And to assess the effect on the MBAA, I use this Poisson hurdle model, because the having 0 interceptor versus at least 1 interceptor are systematically different based on the practice's condition. So overview of the result is preliminary findings. So we found the evidence of the learning. So hypothesis 1, 2 are supported. So it seems that as practice accumulates experience of the online medical consultation, their turnaround time reduces, and they they develop transactive memory system. They know who knows it better, and therefore MVAA, the work coordination problems, reduces. However, we found the evidence of knowledge transfer or learning from indirect experience only in the case of the coordination problem, not the waiting time, which kind of makes sense because who does it after whom kind of this coordination issue is more easily imitated by other practices after discussing about the pros and cons and there's some feedback and best practice. But then turnaround time, the patient wait time is more of a black box. There are so many different factors are associated. And in fact, the magnitude of effect is a little bit disappointingly small. So these are just repeating my findings. We found the evidence of learning and the transactive memory system and the knowledge transfer for one of the cases. And some minor findings are patient-physician encounter mattered in both cases, which means that whether the patient and this particular pair of a patient and a physician had encountered within the most recent 3 years actually reduces the patient wait time as well as the coordination issues. So in that case, the nurses they know exactly who need to take care of the issue. And then also both patient wait time and the coordination issue improve as more office encounters await after the e-visit. So it's kind of aligning with the goal setting theory. It didn't really matter how many office visit patients were there before the e-visit submission. However, how many patients are awaiting after the e-visit submission mattered. So when they have more patients awaiting in the office, they really hurry up. And the patient's health condition, of course, how many comorbidity issues based on Charlson Comorbidity Index affect their operational process. Only a marginal effect on the patient wait time, but then it had a quite significant effect on the coordination problem. So, of course, it's not without the limitation. We only include on one organization, and there are a limited number of physicians and practice involved in this study. And there's a lack of data regarding the actual interaction between physicians and staff, and even between the practices. If we have that, probably we'll be able to drive more detailed knowledge transfer scheme mechanism. And in the future, probably next month or so, I plan to extend the study in order to include organizational forgetting. So whether they have more frequent e-visit arriving or they have really a big delays between e-visit arrival rate, then probably practice does better when they have frequent arrivals, and the practices with really a big arrival rate, not small arrival rate, has a kind of forgetting what they have done. So actually after, for instance, 1 month passed, their operational efficiency actually gets worse. So some of the studies in organizational learning theory found out that effect in manufacturing plant. So I'm going to incorporate that part here as well. Thank you. I still have 19 minutes, 19 seconds.
Let me start with the classic words. I really liked your paper. And actually, I really did like your paper a lot. Why is the audience laughing? Never mind. I think it is a refreshing, novel, and very interesting perspective on the topic. I think, Gordon, you mentioned that in your discussion before. We all love to engage with health IT and to see that the system will actually be better in the end. Alas, 90% of the papers I read start with health IT will make the world better. And where is the evidence, actually? We saw 2 presentations today going into that direction, and your work, Changmi, is actually now taking a slightly different twist to see how does health IT actually affect the process of healthcare delivery from a doctor's and nurse's perspective. So I have not yet read something like that, and I really like that idea and how you went on to that. The findings were interesting. Some of them were counterintuitive, actually. So we saw that the inter-organizational learning effects actually drive down the non-value-added activities, so we have less of these. However, we did not find an impact on the wait times. So why is that? That should have been the other way around. So when NVAA decreases, the wait times should also decrease, but it did not. Interesting thing. And it has some really helpful implications, especially for practice. What we in IS practice give to the practice for years, we preach that change does not happen by itself. Effective usage of a system does not just happen. You actually need to push it. You need to actively enable it. You need to empower the people, to train them to use the system in an effective way, that effectively in the end something will happen. So just don't put a system there and hope the system solves the problem. It does not. Some thoughts for further development. So you're talking about efficiency. So how do we increase efficiency? And the main measurement for that is time. So is time actually really the best measure of efficiency in such a surrounding, in such a context? What is it about the outcome? How does the patient feel? How often did the patient need to show up, be readmitted until actually the patient was cured? So something more like a quality measure. So efficiency alone is a value in itself, but needs to be complemented with other constructs, I think. And the most interesting thing, if you read papers on efficiency, what is so specific about healthcare? Why do we have a specific view on the healthcare context here? And wouldn't it be helpful to put that in perspective with other industries? I mean, other industries are working on efficiency for much longer time. And this is not only the industry, this is also service engineering we are talking about. So it could well be useful to take a look on other industries, how they actually tackled the efficiency problem and how they framed the efficiency construct in there. Going further on on time as your main measurement, I always ask myself what actually influences time here, and what role does the e-visit system, so the information system that organizes all that, play in that? So two basic hypotheses I would come up with just from top of my head. When the business is slow, when the doctors, when the physicians are not fully engaged over the day, shouldn't that decrease the e-visit wait time by itself, because the people have time to actually react faster? What happens, and you put that forward in your presentation as well, what happens if you have a dedicated person being the gatekeeper, doing the triage in the beginning? Shouldn't that decrease the wait time dramatically? The better this person is trained, the better this person knows the doctors, one could assume that the less interaction we have between doctors pushing files back and forward. So just some thoughts here. On to knowledge and learning. It would be very interesting to see what is actually the effect that training has on the whole adoption process and on the overall process efficiency. So is the system just put forward and with the kind words here, nurse, use it? Or did they actually get a training? Is there a training curriculum for the nurses, for the doctors? Do they actually know how to best use the system? How do the differing abilities of physicians affect the wait time? So do we have physicians that are faster than others? It is a dramatic impact on the wait time at all, as defined for the e-visit wait time, but that should be something which should be measured. And I always have this suspicion that there are some physicians that do better with virtual patients than with real life people. Probably you all know House MD, yeah? That's the kind of person I'm talking about. Stay away from the actual human being, go down to the digital data. So are there different types of physicians around there, and what is the impact on the turnaround time? Some thoughts on organizational learning. You had these mixed findings in there. So if the decrease in non-value added activities does not affect the wait time, maybe you need to take a different perspective on it. So if it's just opening and closing of the file, that probably doesn't matter. But how is the slack time associated to the specific non-value added activity? Maybe it's worth taking a look in there to see what actually are these people doing and how does that hinder the process. And some words on information technology before I always saw that I dramatically overdraw my time. That happens frequently. For the computer system, what is actually the role the administrative system plays in all that? Is that like a system that is designed to make it an efficient process, or is that just a system, bling, here goes on a light, a new patient came in? So how actually does the system support the process? You know, the task technology fit discussion. I have a task, I have a technology, and how good is the fit between those two things? And resulting from that, could a higher level of automation actually increase the level of efficiency? In other words, is the system crap? Excuse my French. Systems implementation literature may also be worth a look. So in IS, we did a lot of research on change management, on organizational adoption, on systems implementation. So if you put a new system, a complex system, into an organization, how does the organization adapt to that? How long does it take until this system got its feet really into the organization? How long does it take for the people to change their current working routines? And also we do have a rich body of knowledge in the whole business process management literature. And that talks especially about efficiency of processes. So that may also be worth a look there. So that was about like almost the same time that you used for your presentation. Again, thank you very much. It was a big pleasure. And I think we have like 7 minutes, roughly to 10 to 15, for the open floor to questions to all these three presenters. That is what we call a shortcut.
So I actually have two questions, so you'll have to wait. My first was for Mehmet, which is just a stats question. Are you clustering the standard errors in the estimations? Because it looked like they quadrupled in size when the n went down. Which suggests usually that you have an n problem. So Colin Cameron has a bunch of stuff.
You mean like, how many, because we have a very large database? Is that what you mean? Yeah.
I mean, it would seem that you would need to cluster the standard errors on the hospital, which...
Good suggestion.
Okay, because we just got clubbed with this at Management Science, so people are beginning to pay attention to it more and more. My second was a suggestion for Changmi. The work reminds me a lot of kind of Elena Karanhana's work on e-visits. And the question I had was, is this really an org learning issue? Because you have one organization. And it seems that, as a result of that, comparing the organization versus someone else, what you're really looking at is maybe learning at the team level, which would speak to some of Wally Hopp's work or some of Francisca Gino's, or whether you could break apart individuals and how different individuals learn at a faster or slower rate, and that might up the interest level. Because you're saying, well, as we do this more and more, we get better and better at it, which we kind of know already, but there are different types of physicians, and different types of physicians get better at different rates. The other thing I thought you might look at was the patient queue and how that affects quality. So Dave Anderson and Bruce Golden have some pretty interesting work looking at patient queues and how when they get longer, the quality of care that they get just goes through the floor. So if you could disambiguate, kind of find the boundary conditions along those two dimensions, it could ramp up the interesting factor.
Yeah, thank you very much for the suggestion. In fact, I have another paper of physicians' individual learning. So I was able to capture the exact time the physicians spent on evaluating and respond back to the patients. So that's another part. And I actually separated, because that was already a big chunk of the paper, so I separated this operational efficiency part. But that's a really good point. Each different physician has different different preferences and different speed. So in this study, I only have a practice fixed effect, but I'll look into that because I have the physician's experience information and gender information as well. So I can probably incorporate it. And then it is true. Some physicians are very willing to serve on the online medical consultation. And well, I found in this particular organization, the physicians with huge patient pool are more likely to use the online medical consultation. Yeah, and then whether this is an organization learning issue, that's a really good point. I really have to work on that a little bit more. But then, yes, this is only one organization that's a big issue. And but then when we looked at a lot of literature in this field, the big barrier is the productivity and the higher workload. So barrier perceived by the providers are mostly because of the they assume that they're going to have a lot more workload and their productivity will be especially very bad with this new technology. So I wanted to show them, no, that's not the case. You can improve.
Thanks.
Thank you.
Ladies?
Thank you. So I have two questions. So on the first paper, Niam, could you comment on like the cost benefit of this type of intervention? Like if hospitals were to, like hire scribes to put the records in front of the doctor, like is it worth it? And then on the second paper, I was just, I know you consulted doctors, and so I was just surprised that, or were you surprised that strains were considered to be good diet or conditions to look at for health information exchange? Because I don't think of that as like a condition that requires a lot of care coordination, but I'm definitely interested.
Well, the cost of scribes per hour is, I think, $15 an hour, and they are one of the unique professions within the healthcare industry that I think have one of the highest growth rates, because hospitals have, and all the other medical entities have realized that they have a very high return on investment. In this case, I did not specifically look at the amount of cost reductions for some reasons that the hospitals didn't want to do that, but when you think about 40% in reduction in images and radiology image for an ED costs on average, I think, at $300 in Western New York, then it justifies itself.
It's a good question. We did have extensive discussions with a physician on the value of HIE and in what cases, and identifying strain, sprain, and headache was a choice that is driven by a physician that we talk with. And the idea was that you would expect, if there is any benefit, you would expect less for the strain and sprain. You are right. But the way that it's working out is if you have an X-ray, right, for a strain and sprain, and the patient comes back in 10 days, X-rays are usually, for them, unless there is something else happened to the patient, they're good for about 30 days. People have different opinions about it, but then you're directly saving time by not doing it again. That's why we are seeing some improvement on strain and sprain, and it is kind of consistent story that in headache we are seeing much more improvement than that.
So my question's for Niam, and give the caveat, there's a good chance I just missed something. I only looked at the paper quickly. It looks like the treatment group is conditioned on patients having at least one query from the EHR and having a history of data at the institution with the EHR. So what you're getting from your you're getting good identification from randomized controlled trial, but I think you're using it to calculate the treatment on untreated conditional on expecting the treatment effect to be high. And even if everything I've said, even if every critique I just made is right, it should be mathematically very simple to take the exact same data that you've already, and results you've already arrived at, and use them to calculate a local average treatment effect or set of marginal treatment effects, which would probably be much more policy relevant. Mm-hmm. If I'm right, the local average treatment effect's going to drop, but
No, both treatment and control group patients, the majority of them had some information on the HIE database. I did not look at and see exactly what percentage of them had the information, but I would say with a very high degree of confidence that almost all of them had some information because the HIE has been in place for such a long time and so many data providers are doing.
then why are you conditioning on it being the second visit?
I didn't condition on being second visit.
I misunderstood something in the paper then.
No, I didn't condition on anything.
You're not conditioning on whether or not someone had a query done?
Yes, had a query at the time of visit. So the treatment.
That's going to be treatment on the treated, not an average treatment effect then.
Okay.
But even if that's right, it's an easy thing to address.
Okay, thank you.
Okay, we need to speed up, so quicker questions, quicker answers, please.
Okay, yeah, so just my question relates to the use idea, and I think one of the things is that a lot of these papers who show these HIE use numbers, implicit in that is that they're like too low, which is probably still true, but I think actually what Niam's paper is showing to some extent is actually in some context, the optimal use is 0%, right? In some cases, right? So I think it's useful to think about the bound on what is the actual optimal use of HIE? Like, 100%, obviously I understand why you made that as a design choice, right? But actually the optimal use might be around 20, 30%, 40%. Not all patients are going to, in some cases the cost might actually outweigh it. And actually I had a specific question to you, Niam. I like this randomized trial in practice and clinical context, and I was wondering if you could expand on the data collection. Because one of the things I noticed is that in some cases your treatment group is actually a lot larger than your control group. I'm just wondering kind of what the process was for collecting that data and doing the randomization.
I think in one of the cases, treatment and control groups are pretty much the same size. In the other one, control group is larger, and that is because we were at the ED in one shift per day, and there are 2 other shifts in the ED, and the patients in the other 2 shifts are considered in the control group. So the number of the control group patients increases because we didn't want to eliminate anybody.
So the question is for Mehmet. The first one is maybe you can talk after also is how do you define crowding in
How do you-
a particular setting? And the other one.
Can you repeat the question? I'm sorry, I didn't hear.
Sorry?
Closer to the microphone.
Okay. Crowding. How do you define crowding? And the second one is basically the EDs are now either outsourced. A lot of EDs are outsourcing it to firms that provide all the ED physicians. And that staffing model, if that's in your data set, also in maybe partners, I don't know which hospitals use it in the Massachusetts area, but I know in Pittsburgh, AHN has outsourced ED to a physician group. I'm assuming that might have an impact also in HIE usage as well as the outcomes, length of stay. And you might want to, if you have not, I don't think you have, you might want to look at the staffing issue. But crowding is a question.
Yeah, the crowding, since we have very large database, what we have done is for each, since we can count how many people are getting in and out, if somebody is sitting in the door of this room, by how many people are getting in and out, we can kind of have a number of how many people are actually inside the ED at any point in time. So for a year, for a given year, for 365 days, we create the census data in the ED. And for any given hour, let's say from 8 to 9 a.m. across the 365 days, we calculate the distribution of how many people are in the ED, in the distribution of 365. And we are doing some sensitivity analysis on if when the patient arrives at the ED, if the number of people inside the ED is above 75% of that distribution. That's the final analysis that we have done, but we conduct some sensitivity analysis around that number. So basically on calculating our level yearly census and looking at the distribution and identifying a threshold above which we consider that patient is arriving to a crowded ED versus non-crowded ED and conducting sensitivity analysis. The second question is I think it's a very good one. We haven't thought about that, but it might help. I mean, your idea, I will definitely look into it. It might help with some of the questions that are coming up about this paper. Thank you.
All right. Last question, please.
Hi, my question is for Changmi. There's something I might not have understood, but if I do understand correctly, you are characterizing multiple clinicians accessing patient data as non-value added. And I realize you're controlling for the complexity of the case, but I wonder if that's really an appropriate characterization, and if there's any way that in the data that you have that you can address whether if there's actual clinical information being developed when there are multiple clinicians accessing data, and if there's a difference in quality. Certainly it's less costly and less delay involved in less of this, fewer clinicians accessing the data, but if there's a difference in quality. Thank you.
That's a very good point. Thank you very much. In fact, yeah, I got that question in my mind all the time. So if I discuss about my data with you, please help me in identifying what would be the better variable to identify this issue. Coordination issue. So I do look at the case where the patient had to come back for the same condition they submitted, but we have very few. Out of 2,000, we have less than 10 cases the patient came back. And also, I controlled for the cases, so we know because what made those patients submit the e-visit. So we know the subjects, and then I controlled for the most popular ones, such as sinus cold and back pain, surprisingly. Those cough, but still those conditions didn't really matter much. So yeah, I'm very open to discussion. So after we talk, you can help me to identify better variable. Thank you.
I just want to make one comment on your paper as well. Related to the comment that was just made, it's about care coordination. Since your focus is on primary care practice, I would almost suggest that care coordination is not such a critical issue here, because care coordination arises when you have primary care and specialists involved. Yeah. And this might simply be a matter of a primary care physician speaking to a colleague about a slightly more complicated case that they might have, but I would hate to characterize it as care coordination necessarily.
Thank you very much. That's a very important part.
So, with that final question, that concludes our session. Let me thank the authors once again. Great job.
Fantastic session, and then thank you, Heiko, for the always excellent interaction.
Thank you.